with Module 6, Circadian Rhythm Sleep Disorders, Parasomnias. And I request Dr. Manjari Tripathi, Professor, Department of Neurology, AIIMS, Delhi, to speak about REM sleep behavior disorder, diagnosis and management.
I think we'll catch on with the number of people who come. I suppose you've learnt about the different stages of sleep, and I'm going to talk about something which happens parallelly in sleep, but this happens during the REM sleep. So we know that, REM sleep is a paradox. It is a paradox because the brain activity is highly desynchronized and it is akin to the awake state, but the body is paralyzed or atonic. So basically, there is sleep, but it's associated with atonia, and hence REM sleep is otherwise known as the paradoxical sleep. In children, it is often known as active sleep. This is just to show you where REM sleep behavior disorder figures in the list of parasomnias. So the REM sleep behavior disorder will, as its name is known, occur in REM sleep. And we know that REM is more during the latter part of the night. This we will learn as we go along. So the essential features of REM sleep behavior disorder is this paradox which I mentioned to you, that is lost. So the paradox of an active brain and an atonic body is lost, and there is loss of atonia, and hence RBD is otherwise known as the paradox lost. And this manifests as abnormal phenomenology in terms of abnormal behavior, which emerges during REM sleep and can cause injury and sleep disruption, not only of the patient, but also of the bed partner. And of course, it may be silent in that it may be associated with just subtle muscle twitching or just EMG activity. What is the mechanism? The mechanism is very, very interesting. Half of the sleep researchers in the world have dedicated their whole lives into looking into the mechanism of REM sleep behavior disorder. Now, in the normal state, the brainstem has facilitatory glutaminergic neurons, a particular part of the brainstem which has been documented experimentally by looking at cats and other experimental models, has facilitatory neurons which run down to the medullary inhibitory region, and this further kind of inhibits the motor neurons. So basically, brainstem facilitatory mechanisms to the motor neurons ultimately end up in an inhibition, which results in this atonia, which is over here. This is under normal circumstances. But in REM sleep behavior disorder, this facilitatory mechanisms going down to generate inhibition of the tonic activity of the motor neurons is lost, and so there is a lack of atonia. So this is the mechanism. And this has been shown experimentally, as you can see here. You can see here in REM sleep, this is normal REM sleep. You can see here the EMG is silent, so there is atonia or no EMG activity, and the EEG is active. So this is truly REM, and there is this inhibitory, the red final over here which you see here is inhibitory to the muscle neuron, muscle cell which is inhibitory and hence causes atonia. And here this inhibitory thing is lost, and so there is lack of atonia, and you can see in RBD there is a hyperactivity of the EMG. So that's how it appears in experimental models. There are several diagnostic criteria, but the essential part of the diagnostic criteria is the presence of REM sleep without atonia, and this may not be present physically or seen. It may just be found on EMG tone. And at least one of the following is present: sleep-related injuries, abnormal RBD documented in PSG, and absence of epileptiform activity during REM sleep, and the sleep disturbance is not better explained by another sleep medical or neurological disorder of note, mental disorder, medication use or substance use. So really to say it is idiopathic RBD or RBD, which is truly essentially RBD, you should have ruled out psychiatric disorder and medication use. We'll come to which medicines can cause it. That's for your clinical diagnostic criteria, and you must have these present. There are subtle other features which can be associated with RBD. You can have patients with RBD having an overlap with periodic leg movements, having an overlap with obstructive sleep apnea. You can have people with RBD having excessive daytime somnolence, but this is rather uncommon. So people with RBD often do not complain of EDS. And of course, usually these RBD people are only violent or have dream enacting behavior only in the night. In the morning, they can be very, very pleasant people, and they are not aggressive people by personality. And there is a long-standing history where you will take from the bed partner where during sleep there is, yelling, kicking, jerking, etc. Now, if the person is awakened during that movement, they may remember a part of what is going on. Because it's happening in REM sleep, there is memory to the event, unlike the parasomnia which happens in non-REM sleep, where there is no memory to the event. So there may be partial retained memory, and of course there will be changes in the polysomnogram in terms of the REM densities. Now, what is the epidemiology like? The epidemiology, it is occurring in, it's easy to remember, 0.5% of the general population. But in the Asians, it's supposed to be lower. In a study in Hong Kong, it was just, 0.04. So 0.5. In Asians, it may be lower. And usually 90% of the people are of the male gender, very rarely in women. And usually it's seen in people above 50 to 60 years. If you see RBD in a younger person, you have to suspect certain conditions. And as I said, whenever you see it in the elderly, you have to think of associations like Parkinson's disease, various dementias including diffuse Lewy body disease, Alzheimer's disease. In children, you have an association with narcolepsy. Narcolepsy can have coexisting RBD, though often there is sleep paralysis, and it can also occur in people who have had previous strokes. It's very important to remember, if you see it in the young, please take history of medications, particularly taking antidepressants like SSRIs, venlafaxine, mirtazapine. All these can provoke a RBD. And also in young men, take a history of post-traumatic stress disorder. Any history of trauma in the past is also going to be significant. The onset can be very insidious and gradual. It can also be sudden, especially if it's post-head injury. And of course, there can be none of these diseases can occur in the beginning. And I'll show you data. These diseases, the degenerative diseases, may occur 10 years down the line. So the patient is having RBD for 10 years. And RBD is a harbinger for developing these neurodegenerative conditions like Parkinson's disease or DLBD, etc. There are certain other neurological conditions which are associated with RBD. We can find RBD even in patients with GB syndrome, motor neuron disease, spinocerebellar ataxia of Mercado-Joseph type, in limbic encephalitis, which is non-paraneoplastic. We do find it in children who are autistic, and also, of course, in certain other genetic conditions like xeroderma pigmentosum and Gilles-de la Tourette syndrome. Now, as I said, one of the criteria is to have a history of sleep-related injuries. The second criteria is to have polysomnographic evidence of RBD. So what is the polysomnographic evidence? There's an increased sustained EMG activity in REM sleep. There is loss of atonia, which may be intermittent. So it may be sustained or intermittent. And there's excessive phasic activity, which is muscle twitch. And about 75% of them may have associated periodic leg movements in your recording in non-REM sleep. And it's essential that the PSG have both upper and lower limb monitoring, and if need be, the paraspinals are also sampled. There are certain other terminologies which we should be familiar with. You needn't always have the full-blown REM sleep behavior disorder. You can have REM sleep without atonia. That is, there is no enactment, but there is just lack of atonia. The person can have a dream enactment behavior, and this can be seen in various associated comorbidities like OSA, sleepwalking, sleep terrors, and post-alcohol or drug use. So what are the polysomnographic criteria in details? I told you there has to be sustained or intermittent. So how sustained and how intermittent? So each sleep epoch is of 30 seconds. One page of sleep which we see is 30 seconds. So 50% or more of this epoch has to have the lack of atonia. So if you see 30 seconds, 50%, that is 15 seconds or little more than that, has to have lack of atonia in the REM sleep. Or if you divide this 30-second epoch into 3 mini epochs, so how many seconds will it be? 30 divided by 3, 10 millisecond epochs. So you have 10, 10, 10. In this 10 millisecond epochs, you have 3-second mini epochs of at least 50%. So 10-second mini epoch further divided into 50, that is going to be at least 3 seconds of these mini epochs of 10 seconds, which you have divided in this 30-second page. They have to have a lack of atonia in REM sleep, and it usually should last between 0.1 to 5 seconds. And the amplitude should be 4 times higher than the baseline background EMG amplitude. So these are the specifics. So either you have a continuous sustained lack of atonia of more than 50% of your 30-second epoch, or you divide your 30-second epochs into 3 mini epochs, and of that you have at least 3-second mini epochs in this 10 millisecond of more than 4-fold increase in the EMG amplitude. This can be seen in the chin, as well as it can be seen in the limb or the paraspinals, however you have programmed it. So this is the REM sustained more than 50 seconds, sustained lack of atonia. So you can see here, the patient starts out with REM atonia, and you can see a more than 4% rise in the muscle tone which is happening. And this is the REM sleep, because you see the eye montage here. The eye montage is showing the rapid eye movements. So this is happening in REM sleep. There is atonia to start with, and more than 50% of the epoch. This is a 30-second epoch, and you have the 10-second mini epochs over here, 1 10-second, 2 10-second, third 10-second. More than 50% of this 30% epoch is showing an increase in muscle tone. As I said, you need not have, if you divide it into mini epochs of 1, 2, 3, so 30-second mini epochs of 10 seconds each, you are having more than 3 mini epochs showing this increase in tone, though it's not always 4 times more than normal, but there is a suspicion that this could be, and it's happening in REM sleep because the upper eye channels, which are REM, are showing a nice REM over here, and you can see a desynchronized EEG. So it is in REM sleep, and you look here, we have put the paraspinal muscle EMG also, and you can see this mini epochs of 3 seconds each at 3 or 4 different places are showing an increase in muscle tone. So this is the polysomnographic criteria for saying that the patient has RBD. Of course, there are other things which should be fulfilled according to the American Academy of Sleep Medicine, which has stringent criteria. It has to be time synchronized with the video and the audio, and the EEG epoch have to be time synchronized. So most decent recent polysomnography machines will have this, and wherever there is visible twitching, it is fine, but you must have, where there's no visible twitching, you must have electrodes over larger muscle groups. And of course, what are the downsides? So this slide is given to me by Dr. Kailash Schenk, who's done a lot of work on RBD. As you can see, people who have RBD are a danger for the bed partner, because when they are thrashing about and having this behavior disorder, which may be violent at times, they may beat up the bed partner. And this is not the patient, this is the bed partner who's sustained bruises because the patient has injured. So these are the, problems with RBD. There can be bruises, There have been documentations of subdural hematomas where they fall off the bed. There can be lacerations, there can be fractures and dislocations. There can be tooth chipping or breaking. Hair pulling, a bunch of hair is pulled out in the night of the bed partner, so you can imagine the misery. And sprains and rug burns. So all these can happen to the bed partner as well as the patient because they may fall off the bed. So I don't know if the video will work. It doesn't seem to be working. So anyway, this is a young man who twitches in the night. So he's just moving around, distal muscles move around. And you can see here that he doesn't fulfill the 50% criteria, but then he has more than 4-fold increase in 3 epochs at 3 or more places in REM sleep. This is REM. This is the older ASM montage. This was probably the first patient of RBD I found. So he has this intermittent 4-fold increase in the muscle activity in REM sleep. And this is a young man with REM sleep behavior disorder. He was young. He was not old. He was like 24 or 25 and he had just got married. So we were wondering why does such a young man have this? And he was on multiple antidepressants. He didn't have a job. He was taking sertraline. He was taking cough syrups. He was taking tramadol. So he was a drug addict, and because of which you didn't have the sustained EMG loss of tone, atonia, but you had this phasic intermittent increase. So this is another patient who actually shouts out in sleep. I don't think the video will play. And this is his, you can see more than 50%. And here, loss of chin tone. And this is preceded by this, he shouts out over here. So he shouts out here, and then there is this lack of, there is atonia before it, and there is atonia after it. So this is definitely more than 50% fulfills the criteria for ASM criteria for RBD. So this is another patient who's actually talking in sleep. So I told you about these drugs. So please take a drug history in both young and old people, because this is just to show you how all the drugs, including selegiline, carbamazepine, imipramine, chlorimipramine, fluoxetine, mirtazapine, tramadol. Tramadol is so widely abused. All of them can cause RBD. So if you have particularly a young patient, please do not forget to take this history. In children, you may have RBD or RBD-like movements, which are thrashing about and moving around in bed. And this can be seen along with narcolepsy. So always ask the parent if there is any history of drugs. The child could be on antihistaminics, or the child could be on drugs for autism, or the child could be a narcoleptic. So take all this history from the parents. In children, there are other causes. There could be brainstem tumors, there could be Tourette's syndrome, even in West syndrome and congenital Mobius syndrome. So these are all the syndromes where, autism is also a very important thing. We've seen many autistic children when we do polysomnography in them, because we have fairly active pediatric neurology which refers these patients to us. So many autistic children, they are on so many drugs. They are on aripiprazole, they are on methylphenidate, they are on all kind of drugs, and when you do the polysomnography, you find the atonia is not there, and so that is probably an indication that it's either part of the autism spectrum disorder or due to the drugs which are being used. So how do you manage? The management is actually very, very simple. It's the simplest of all things. A very low dose of clonazepam can be used to the tune of, I have used 0.125 milligram in elderly people. In elderly people, we don't go with high doses because it causes sedation and it can cause falls. So you have to really start low, and really they respond very well to 0.125. Sometimes you may need to hike up to 0.25. Rarely have I gone up to this dose. I don't remember ever using a 2 milligram dose in my patients. And of course, it works by suppressing the phasic motor activity. We also use melatonin, though melatonin is not as good in its, efficacy as clonazepam, and generally, typically, I start with 3 milligram. We have only synthetic melatonin available to us, and I give melatonin more often to elderly because they have neurodegenerative disorder, and if you give them clonazepam, one is the risk of habituation and addiction, and the second is, of course, the risk of falls. So I tend to start with melatonin in my very elderly people. Pramipexole can also be used, particularly when it is associated, as I told you, 75% of them can have periodic leg movements. So there, or restless leg movements, and there you could use pramipexole, and sometimes clonidine and carbamazepine can be used. Of course, you have to work on maximizing the safety of the patient. The patient should be in an environment where the bed is, kind of not having, he should not be sleeping on a height. I often tell my patients to put the mattress on the floor, and there should be no glass windows or, near the bed. Sometimes just next to the bed you have a glass window and they beat the glass and they can injure themselves. And if there's a glass, it should be unbreakable kind of. And of course, the bed partner needs to be at a distance. And these are, so there's the bedding. The bedding has got a cushion here, and the bedding has got a cushion here, and the patient is sleeping here. And sometimes the patients tie themselves. Again, this is given by Carl Schenk. So you can, but the downside of these restraint is the patient can strangulate himself. So you really don't want them doing this. I'll conclude by saying that whenever you see a patient who's in the 30s, 40s with RBD, please follow these patients for a long time, because many of them, this is the first manifestation of a neurodegenerative disorder. And this is well described by the Minneapolis group, where after 10 years, they find that there is emergence of Parkinson's disease, there's emergence of DLBD, there's emergence of Alzheimer's. So to the tune of 50%, 50 to 60% of these patients will go on. And some studies say even 70 to 80% will go on 10 years later to have these diseases. So you must follow these patients up. I think my time is up, though I have some more slides. But if there are any questions regarding this, I would be glad to answer. Thank you. Any questions? How many of the students here have seen a patient with RBD? Can I have a show of hands? Okay, how many of you all have asked if there is any movement in sleep? Because very often you miss the diagnosis of RBD because you have not asked. So make it a habit, particularly for the students, when you're seeing a patient, every patient, like you take personal history, smoking, alcohol, sleep is a part of it. Sleep should be a part of your personal history. Once you finish the chief complaints, please go back and ask, how's your sleep? How many hours you sleep? Ask a caregiver, is there any problem in sleep? Does he move in sleep? Then only you will get the history, otherwise you will completely miss the boat. Thank you.
Thank you, ma'am. Now I request Dr. Saraswati Muppanna, internal medicine specialist, to talk on circadian rhythm sleep disorders.
Good morning, everybody. What do I do next? This is the front. This is the back. Pointer. Okay. Do they have a mic? Do you have a mic? Okay.
And this pointer works only here.
Like this.
It will, if you just point it here.
Sorted with that?
Okay. Good morning, everybody. I would like to thank Dr. Srivatsava, Dr. Malik, and Dr. Jindal for giving me this opportunity today. And my talk today is on the circadian rhythm sleep-wake disorders. And I just want to find out about the time. What is the time? How much time do I have? I have 45 minutes. 30 minutes. No, 45 minutes. Starts now. Okay. So my talk today is on circadian rhythm sleep-wake disorders. And I'm going to talk on, first about the introduction, what it's about, and the circadian rhythm biology, the circadian phase markers, the international ICSD classification, recognition, and management of these disorders, and in the newer developments in terms of markers, what are available now, and circadian rhythm and other associated conditions. So this is the anatomy and physiology of the circadian rhythm. What you see here, so when you see light entering through the eyes, it's going into the retinohypothalamic tract. And it goes into the suprachiasmatic nucleus, and through that it actually goes into, it goes into the superior cervical ganglion and into the pineal gland, where pineal gland is the seat of melatonin secretion, and light causes inhibition of the release of melatonin, whereas when there's no light and it's nighttime, stimulation of the melatonin happens. That's how it causes us the inertia to sleep. So the circadian rhythm is a 24.2-hour circadian rhythm, but it's entering to a 24 hours, and that's with the help of the Zeitgebers. The Zeitgebers are two types, the photic and the non-photic. The photic one is the light. That's the basic one, and it's the most powerful one. The non-photic ones are the melatonin, feeding, exercise. It could be social interaction, any of those. So this is a suprachiasmatic nucleus input. You see the retinal signaling here, and what you see here is the cones and the rods, and they're relaying signals, and which all go into the suprachiasmatic nucleus here. We also have the circadian clock genes. These genes, one is the clock gene you have, two is the PER1 and the PER2. These actually reduce the sleep. The other ones are the CRY1 and 2, and you have the BMAL1, which increase the non-REM sleep, and the BMAL1 actually increases the total sleep time. So this actually shows how all these signaling happens with the ultimate effect of the metabolic rhythms. It causes neuronal firing, it causes neuropeptide secretion, it causes gene expression, and controls the behavioral state. So this is again talking about during the night time, degradation happens with the CRY and the PER, and there's release of the CRY1 and CRY2, which help in increasing the non-REM sleep. So what happens? How do we regulate sleep-wake regulation? How does it happen? It happens by two processes. One is the process S, and the second one is the process C. The process S is the homeostatic drive. So when we are all awake, right, 14 to 16 hours we are awake during the daytime, and that causes an inertia. You start feeling sleepy and drowsy during evening time. That's because of the process S, which happens here. And this is what you see, the process S, it starts building up, and then you start feeling sleepy, and you are falling asleep here. The second one is a process C. That's the intrinsic circadian rhythm, and what that does is that also causes us to fall asleep, and again you wake up in the morning. All this provided your internal circadian rhythm is healthy. So if you look at the sleep drive, again, your sleep drive inertia is increasing, and then you fall asleep here. So this yellow bar, the whole one is the sleep time, and in the morning, the sleep drive reduces, and you're awake during the daytime. So the circadian rhythm at the bottom here, this actually coincides with the sleep drive in a normal, healthy circadian rhythm person, and both together help us to sleep better at nighttime, and in the morning, actually, the drive comes down again. So if you see here, the bottom one is the melatonin. From 9 p.m. on, it's being released, and it peaks around 3 a.m. or so, and then it falls off around 7 or 8 a.m., and that's how you have the sleep pattern coming here. So the two markers, the most important markers are the core body temperature, and the second one is the dim light melatonin onset. So if you see here, there's a drop in temperature which is associated with the stability in sleep. There are 3 dips. One dip is 3 to 5 a.m. The second dip is in the afternoon between 1 and 4 p.m. And the third dip is in the morning, 3 to 5 a.m. As I mentioned, the second marker is the melatonin secretion, and it increases in level around 8 p.m., max off at 3 a.m., then starts falling off at 7 a.m. So if you look at this, this is the core temperature as it's coming down during the sleep period, and then it raises again, the core body temperature raises again, and we are awake. So this core body temperature minimum, it is 2 to 3 hours before sleep offset. Please remember this, it is 2 to 3 hours before sleep offset. So it technically should be here. There's an error in my graph. And the second one is a dim light melatonin onset. This dim light melatonin onset is 2 hours before the sleep onset. It's at the bottom here. So if your habitual sleep pattern is from 23 hours till morning 7 a.m., then 2 to 3 hours before that is when you have the DLMO dipping here. So this is important because advanced and delayed sleep patterns are calculated by this. So this is the phase shifting. You see the light phase response curve, and here you see the habitual sleep time. Slow, you look at here 0 to 8 o'clock, 8 in the morning. That is the habitual sleep time in this graph. And to bring to an earlier time, what you're doing is you're giving the light as a stimulus. So if you give light as a stimulus here, you see that the graph is, your whole sleep time is being pushed out to a later time. So this is to do with the melatonin. 2 to 3 hours before bedtime, it starts increasing. That's how you see this sleep pattern which is shown here. So now if there's any problem with the circadian rhythm, this actually causes the circadian rhythm sleep-wake disorders. The criteria should be met between A and C. The first one is a chronic and recurrent pattern of sleep-wake disruption. You have the external clock and the internal clock. So there are problems. If there is a malalignment between the external clock and our internal circadian clock, that is one criteria. And 2 is it leads to symptoms. Like the patient can have insomnia, they can feel very sleepy, and it's also causing a disturbance in their quality of life. So there are 6 disorders in the circadian rhythm sleep-wake whole category. There's something we divided into intrinsic and we divided into extrinsic. First, let's look at the intrinsic. There are 2 phase disorders and 2 rhythm disorders. So total of 4. So the 2 phase disorders are delayed sleep phase and advanced sleep phase. And the 2 rhythm disorders are irregular sleep wake and non-24-hour sleep wake. Apart from that, there's something external, extrinsic or exogenous rhythm, circadian rhythm sleep wake disorders. That's to do with the shift work and to do with the jet lag. And there's another category which says circadian sleep-wake disorder not otherwise specified. And this one, we don't know what the reason is. That's why they call it NOS. So this is case 1, a teenager, 17-year-old. He's falling asleep. He has difficulty falling asleep at night for the past 3 years. So it is a chronic condition. His bedtime, he tries to go to bed at 11 p.m., but then he tosses and turns, not able to fall asleep. And in the morning at 8 o'clock, when he's supposed to wake up to go to school, he snoozes his alarm and he misses his 9 o'clock class. I'm sure most of you have experienced this in terms of friends or family members, any teenagers in the family, you must have noticed this. And when he misses his class, what happens is he nods off. He does have afternoon naps and he feels very sleepy. And around 9 p.m., he tries to take, he takes a short nap. But what happens is during summertime or during his weekends, he's able to sleep better. His regular sleep timings are between 2 a.m. till about 11 a.m. So that time he's able to sleep well. So what do you think is the diagnosis? Any takers? Anybody? Okay, so this is a delayed sleep phase. Delayed sleep phase disorder. The question here is, which of the following diagnostic tools is the most appropriate to confirm the suspected diagnosis? Would it be a 24-hour recording of the core body temperature with a rectal thermometer, or an overnight sleep study, or an actigraphy recording, or you got history, that's enough to make a diagnosis? Any takers for this one? Sorry? Actigraphy, that's right. So here you see, this is the normal. The gray bar is a normal sleep cycle, right? Habitual sleep pattern from midnight till about 8 o'clock. So in this patient, what's happening is it's totally shifted. He's able to sleep from 2 o'clock in the morning, and then he's waking up around 11. That's his good sleep cycle. So that's what you see here. It's around 2 or 3 in the morning, and then he's waking up around 11 or 12. This is a delayed sleep-wake phase disorder. Now, how do you treat this? Even before that, what is the ICSD criteria for this? Main thing is they have to have a significant delay in the major sleep episode. That's number one. And then they must be present for at least 3 months. And when you allow them to sleep on their own timings, they do really well. They sleep well. They have good quality sleep. And you need to do an actigraph at least for 7 days to 14 days. And it should not be, these sleep-related symptoms should not be accounted for because of medications or any other psychiatric problem or any other issues. So that's how we make the diagnosis for the delayed sleep-wake phase disorder. So you're right, it's an actigraphy recording that will confirm the diagnosis. It'll help in confirming the diagnosis. So this is how it looks. So if you look here, that's a normal sleep time. From here to here, that's a normal sleep time. Traditional sleep time is either 10 p.m. to 6 a.m. or 11 p.m. to 7 a.m. But here you can see that it's shifted. It's around 1 to 2 a.m. And he's sleeping all the way till about 11 to noon. So this is a continuation of the same question. Which of the following treatment regimens do you want to start? You want to give him modafinil because he's feeling sleepy during daytime, or you want to give him zolpidem at bedtime and refer him to CBT for insomnia, or you want to give him melatonin and light therapy, or you want to give him melatonin light therapy with 1 milligram at 8 p.m. and give him bright light therapy 1 hour upon awakening. Any takers for this one? Okay, so you're giving melatonin 3 milligrams at 2 a.m.? Is that what you wanted to say? Okay, let's see. So you're giving melatonin 1 milligram at 8 a.m. Okay, so you're trying to allow him to sleep. And then in the morning when he wakes up, that's when you give the bright light therapy. So otherwise he's feeling sleepy during daytime, right? You want to avoid that as well. So if you see here, this is his habitual natural sleep time from 2 in the morning till about 10 or 11 a.m., right? That's his sleep time. And here you see the core body temperature minimum is dropping around 8 a.m. or so, 8 or 9 a.m. So you want to give light therapy after that. That's the key. That's how you'll advance it. And then you're going to give melatonin before his bedtime, around 8 o'clock or so. So this is how you treat the delayed sleep phase. So you see the post-awakening light treatment with behavioral treatment in children and adolescents. And you give timed melatonin in adults, 0.3 to 5 milligrams, you can do that. The pathophysiology is mainly the HPER3 gene, and there's also a prolonged circadian tau, which happens here. And there's an abnormality between the process C and the process S, which goes on. So case 2, this is a 70, even before I go there, what will be the implications for this delayed sleep phase? There's a lot of problem. The teenagers, they have this delayed sleep phase. What happens is they go to school late and they skip their morning classes, and So that becomes, they have falling grades, so it becomes a huge issue for them. So that's why it's really important for us to identify the deep delayed sleep phase and also to be able to treat it. So the case 2, 72-year-old male comes to your clinic for evening sleepiness and inability to remain asleep throughout the early morning hours since moving in with his son's family 6 months ago. So the timeline is 6 months ago, and he's trying to stay on their schedule, the son's schedule, not on his sleep schedule. And when he was living on his own, he had no problems, right? And you get an actigraphy which shows this pattern. So this is 6 o'clock in the evening to about 5 a.m. And you can see how it's moved out, right? It's moved all the way, it's advanced. So you get an actigraphy. What does the history and actigraphy suggest? Any takers for this one? So this is the advanced sleep phase disorder, and it's similar for most of these phase disorders and rhythm disorders. The most important thing is they need to be there, the symptoms should be there for 3 months at least, and they shouldn't have any other comorbidities which could give us a differential diagnosis. And when you let them sleep on their own, they should have good sleep quality. Supposing an advanced sleep-wake phase disorder, right, if they're going to bed around 8 p.m. and they're waking up at 3 or 4 a.m., you let them do that, they have a good quality sleep. But then what we are trying to do is we are trying to move them to a traditional sleep-wake pattern. That's where the problem arises. So this is a normal sleeper, and you can see a specified time, maybe 10 p.m. to around 6 a.m., but then in this advanced sleep phase, you see that shift. You see the shift here. It's from 8 p.m. to around 3 or 4 a.m. So the second part of the question is, what time is the estimated DLMO and when should light therapy begin? How do you want to treat these patients? That's the basic thing. So either you want to give them the DLMO at 8 o'clock and light therapy at 3 in the morning, or you want to give light therapy at 5 p.m., or you want to give the DLMO at 5 p.m. and give light therapy at 3 in the morning, or you want to give the DLMO at 5 p.m. and give the light therapy also at 5 p.m. Any takers for this one? This is a hard one. Any guess? B? D? C? Okay. No A and B, right? Oh, you said B. So here, if you look at this, you don't want to do the DLMO at 8 o'clock, right? And light therapy at 3 in the morning, it's too early in the morning. You don't want to do that. So if you look here, the answer is D. The answer is D here. Sleep onset typically is between 9 and 10 p.m. The estimated DLMO should be 2 hours. As I mentioned before in one of the previous graphs, it has to be 2 hours before their habitual sleep time, right? That's 5 to 6 p.m. And here you see here the patient is actually going to bed at around 6 or 7 o'clock in the evening. That's too early. So D is the answer for this patient. So the DLMO is around 5, and you give the light therapy also around 5. So you're trying to push the sleep time. So for the advanced sleep phase, evening light therapy is the most important treatment method for this patient. There's been a study, they give around 4,000 lux white light for 2 hours between 8 p.m. and 11 p.m. And then the core body temperature minimum, there was a delay for 141 minutes, and the total sleep time increased by 51 minutes. Pathophysiology, again, it happens in older individuals. So the main mutation is the HPER2. The social implications of this particular disorder is, you know, the parents, elderly parents, they're waking up at 3 or 4 in the morning, but then the rest of the family is sleeping. What happens is these elderly parents, they might walk around and do their stuff at 4 in the morning, and it's causing a disturbance to the rest of the members, and they are not able to sleep well. That is one huge factor. And then there have also been falls at that time of the day or that time of the night. So advanced sleep phase in elderly patient population is becoming a huge problem. If you see this in a younger individual, it could be mainly because of the family history, because of an autosomal dominant inheritance. Question 3, a patient with irregular sleep-wake rhythm disorder, which of the following is true? You give the bedtime melatonin, improves sleep and daytime function in adults with dementia, or bedtime melatonin effective treatment in children with severe developmental disorders, bright light treatment resulted in insomnia in nursing home patients, or hypnotics are an effective treatment in adults. Any takers for this one? Just make an good guess. Okay. What is irregular sleep-wake rhythm disorder? First of all, according to the ICSD-3 diagnostic criteria, again, it's chronic or recurrent pattern of irregular sleep and wake episodes throughout the 24-hour period. So what happens is they have insomnia, but then they take frequent naps during the day, and again, 3 months, actigraphy you have to do, and what do you do in the actigraphy? You'll find that there's no major sleep period, continuous sleep period. They're also fragmented, and they have 3 such fragments at least in a 24-hour period. So just like what I said, main sleep bout is absent here. You don't see this huge block here, right? This is all so fragmented. They need to have at least 3 sleep episodes in a day and 2 to 4 hours each. This is seen mainly in patients with dementia, in children with autism and Asperger's, and this is because of the impaired function of the circadian clock or restricted access to light or any of the other stimulants. How do you treat this? If it's in children, then you give strategically timed melatonin. Okay, if it's an elderly with dementia, light therapy. That's the only thing, it's light therapy. Hypnotics, they're not a big favorite. You shouldn't be trying hypnotics in these patients. It's mainly light therapy. That's what is recommended. So the answer for this one is, because it's a child with severe developmental disorders like autism or Asperger's, you give bedtime melatonin. Case 4, this is a sleep diary of a 36-year-old male, intermittent insomnia, daytime sleepiness. You see it here, plotted here. What is the likely diagnosis? This is day 1, and as you're going down this axis, you see day 57. You see this pattern, how it's just moving. You can see every night, their sleep timings are so different, and they're just falling off like this. The diagnosis is a non-24-hour sleep-wake rhythm disorder. Do you know where you see this? Okay. The continuation of this question is sleep diaries we saw here. You see these circles here? What do you think these circles are, and what do you think these markers, these black marks are? That's the question here. It says melatonin. Is it melatonin 1 or 15 milligrams? And did you give a stimulant for the patient to wake up early, or did you give light therapy? That's the basic question here. So what is the criteria for making a diagnosis of the non-24-hour? Main thing is insomnia, excessive daytime sleepiness, alternate with asymptomatic episodes because of the misalignment between the 24-hour light-dark cycles, and they're not able to entrain the endogenous circadian rhythm. That's the main problem in these patients. And you see this mainly in patients who are blind. So this is how the pattern looks. You can see one night it's good. They're on a traditional sleep hours. But then the next night on, they start moving. Their sleep time starts shifting, and it starts shifting. Okay, and then again, after a few days, it might come back to this. But it'll keep shifting always. So these patients, 50% of them are totally blind. and they're not able to entrain the 24-hour days. That's the main problem with these patients. So you give this patient melatonin 1 milligram. That's what they did here. These places, they've given the 1 milligram melatonin. And here, if you see, they tried the light therapy. And you can see, just for these few days alone, how the sleep-wake schedule has been good. But later on, it starts falling off. When they didn't give the melatonin, didn't do the light therapy, it starts going off again as a non-24-hour rhythm. So how do you treat this? This is, you give strategically timed melatonin in blind adults. That's the treatment for this disorder. So coming to jet lag, here if you see, on the right-hand side, you see here, 12:17 a.m. the Eastern Standard Time, and here in Hawaii, it's 5 p.m. already, or 7 p.m., and it's time to go to bed. So there's always a time difference, and there's time zones also. Jet lag disorder, according to the ICSD, they have to have complaints of insomnia, daytime sleepiness, reduction in the total sleep time, and they have to have changed at least 2 time zones. That's really important. And it's associated with impairment of the daytime functioning and not explained by any other condition. So time zones, either you lose time or gain time as you're moving from one place to another place. And Earth is divided into 24 time zones because there are 24 hours in a day. So case 5, Dr. Smith, 48-year-old, no past medical history. He is traveling from Detroit, Eastern time zone, to British summer time zone, which is in London, which is 5 hours ahead. And he sleeps well at home, 11 p.m. to 7 a.m. But however, during his previous trip, he had some jet lag and he had trouble falling asleep at night. He reached London airport at 11:15 in the morning. So you're trying to prevent jet lag. What would you recommend for this patient? You're going to give him bright light. You're going to avoid bright light upon arrival in London, or you're going to give him bright light upon arrival and give him melatonin 3 milligrams at bedtime, or you're going to give him melatonin at 4 p.m. and try to ask him to go to bed at 11 p.m., or you're going to give him melatonin upon arriving and avoiding bright light, wearing dark sunglasses. Any takers for this one? So when you're doing a jet lag disorder problem, solving this problem, always please make sure that you mark the timing of the home. This patient was traveling from Detroit, so put the timings there on top, and then wherever he's going to, put the timings there, and then you mark on here what is his habitual or natural sleep time. After the core body temperature minimum, that's when you start giving him the light. Sorry? Oh, okay. So then you start giving him the light therapy. So you give him light therapy after his core body temperature minimum is passed, and then give him melatonin before his bedtime. So that's how you do jet lag. So please make sure you put the timings on top of the home and timings of where he's landed, and then work your way through this. So the answer for this is seek bright light upon arrival and throughout the afternoon, and take melatonin at bedtime. So generally, jet lag, there are a few principles for jet lag. If they're crossing more than 8 time zones, it doesn't matter whether you're delaying it or whether you're trying to advance it. The main thing is, if you're traveling from Chennai to Japan, right, you want to actually advance your sleep cycle by 1 hour, and then in the morning you try to have bright light. So that's one thing you want to remember. The rest of it is everything is delayed. And if you're crossing more than 8 time zones, as I mentioned, advancing or delaying the phase, it really doesn't matter. And when you're traveling for 2 days or less than 2 days, stay on your home sleep time. So for the jet lag, melatonin is the main thing, what is proven to be of some benefit. and morning bright light and 1 hour advance of sleep schedule. You should do this even before you travel to Japan from Chennai, okay, not after going there. And then benzodiazepines like zolpidem and zaleplon, they have some benefit. And caffeine, it can help you with your sleepiness, but not much. So case 6, 37-year-old male reports insomnia and is falling asleep at work. And he's a respiratory therapist. His shift is 7 p.m. to 7 a.m. And he lives in Chennai and has a long commute. He goes to bed at 8:30 a.m. but tosses and turns, and he sleeps only for 3 hours. Sleep is fragmented. 3 p.m. he's not able to sleep anymore, so he gets out of bed. He feels exhausted at work. And when he's day off, that time he sleeps well like a normal person from 11 p.m. to 7 a.m. So what is this one? Any takers? What's the diagnosis for this one? So it's a shift work disorder. And to do with the rest of the question, which of the following interventions has been shown to maximize both circadian alignment and alertness? So is it modafinil or melatonin, 5 milligrams prior to the daytime sleep, or is it bright light exposure during his shift and sunglasses on the commute home, or napping along with caffeine? Anybody? Okay. So what is the diagnostic criteria for shift work disorder, right? They should have a reduction in the total sleep time and associated with a recurring work schedule that overlaps the usual time for sleep. So during the time when they're supposed to be awake, they're trying to sleep, and they're working the opposite, right? And at least for 3 months, you do an actigraphy again, and this disturbance should not be explained by any other condition. So this is the day worker. You're awake here, and you get your consolidated nighttime sleep. And this is your shift work. You see here, it's all fragmented daytime sleep. They're trying to sleep during daytime, but then there's a circadian disruption. They're not able to sleep properly. And then at nighttime, when they're supposed to be sleeping, they're awake, and there is a disruption between the circadian and the homeostatic effects. So shift work disorder, they can be doing nights few days, and then they could be having rotating shifts. So it's kind of little all over the place according to the work timings. So how do you treat them? You try to regularize their shifts, good sleep hygiene, schedule naps, and exercise and light exposure. Circadian alignment, how do you do in night shift work? The most important thing is giving light when they go to work at night time. That's what is going to keep them awake. Okay, that's the most important thing. It's found to be beneficial even more than melatonin. So alertness in shift work, bright light therapy, that's the one. You can give them modafinil and coffee, napping, but then melatonin, not much. Mixed results. Hypnotics, not much at all. So for this patient, both the circadian alignment and alertness, bright light exposure during shift and sunglasses on the way home. That's the most important thing. If it was only alertness, you could give them modafinil, right? But that's not the recommendation. So this is a gist of everything what I discussed now. The delayed sleep-wake phase disorder, advanced sleep-wake, irregular sleep-wake, and non-24-hour sleep-wake. The most common things are they have to be at least for 3 months. You have to do an actigraphy, and their symptoms should not be explained by any other conditions. And when you let them sleep in their own time, like 2 a.m. to 11 a.m. in a delayed sleep phase or in a teenager, they should be able to sleep well. So those are the main things. Shift work. It's a reduced total sleep time and jet lag, 2 or more time zones. So those are the points you want to remember. And dim light, melatonin onset, 2 hours before habitual sleep onset. This is something you might get in your board, so it's really helpful to remember this. The core body temperature, minimum 2 to 3 hours before habitual sleep offset. So just before waking up, 2 to 3 hours before that is a core body temperature will be minimum. And before you're falling asleep, right, 2 to 3 hours before that will be the DLMO. I'm just going to skip this. So the guidelines For advanced sleep phase, evening light, that's the treatment. For delayed sleep in adults, you give melatonin. In children, post-awakening light and behavioral therapy. If it's a non-24 blind patients, you give them melatonin. If it is irregular sleep-wake, in elderly patients with dementia, give them light, no hypnotics. And kids, you give them melatonin. Jet lag. Jet lag, advance after eastward travel. That's the most important thing. I mentioned Chennai to Japan. You have to advance it even before you catch your flight. That's important. And more than 8 time zones, it's mostly delayed. And shift work problems, modafinil, they're the only FDA-approved treatments for sleepiness and shift work disorder. So newer developments in markers. So this is actually from a single blood sample. This came out in the Journal of Clinical Investigation in 2018. What you see here is you take a single blood sample here, and the monocytes, they have the 12 genes. They are able to detect and tell us about the internal time. Not just the core body temperature, not just the melatonin, but this is something which is coming up now. You take a single blood test and you'll be able to tell what your internal time or clock is. So what happens is when you do the blood test, they actually go through a biomarkers, they go to the nanostring platform, and then that actually tells us about their clock time. So circadian rhythm and other associated conditions. My talk won't be complete if I don't talk about what is the latest in circadian rhythm and other body organs, what is going on. So there's a wide metabolism, there's a wide coordination between different clocks. So let me explain this to you. Okay. Right. Why is it coming like that? No, this has nothing to do with that. Okay. So, thank you. Thanks. Okay. Okay. So, eating, insulin receptors, then you have the mRNA translation process happens, and you have the per signals going on, the genes going on, and diverse cell types. You have the neurons, and then you have the GI cells, the muscles. And you see these have their own circadian clocks in them, right? So this is what happens. Central peripheral synchrony needs to be there for us to be able to be healthy. When there's sunlight, the suprachiasmatic nucleus gets stimulated. This is a normal pattern. And when you eat food, it actually stimulates both the liver and the GI system. Just the sunlight and the suprachiasmatic nucleus alone, normally they stimulate the peripheral circadian clocks which are present in your liver and your gut. And the food is also stimulating your liver and your gut. So whenever you have a shift work person or a jet lag person or social jet lag or abnormal food timings, the whole thing shifts. What happens is there is a desynchrony between the central system of the suprachiasmatic nucleus and the sunlight, and there's a misalignment, and your eating habits also change. The food becomes more like French fries and McDonald's here. And there's a problem with the liver and also problem with the gut. So you have NASH, you have non-alcoholic steatohepatitis, you can have all these GI problems and the liver problems which happen. And nowadays, they feel that there could be circadian-based therapeutic interventions So you can teach patients about the circadian hygiene. You can tell them about chronotherapy. You can tell them about melatonin and the GI diseases. You can also tell them about clock targeting pharmacotherapy. So these are the latest things which are happening now. So if you look at this is again the location of the clock here, the same thing what I've explained. This is the central system, circadian stimulation, what is happening. And these are all the peripheral clocks. You name it, in all the major organs you have your own, there are these tiny peripheral clocks which are happening here. And they actually cause, if there's a problem with this whole central and peripheral desynchrony happens in the organs, it causes desynchrony among the cells and also desynchrony among the clock genes, the BMOL and the PER and the CRIs. Okay. Just to go into detail a little more about this one, this is actually the food intake in the central circadian clock. You have the daily oscillations in the microbiota. This is in the intestinal lining, the gut microbiota and the gut epithelium. They have their own gut circadian clock. So this is going a little more into detail. There's a lot of research going on now in the gut microbiota and the circadian rhythm. And I think we'll have more to say next year. So this is something diet-induced circadian enhancer. It's a remodeling, synchronizes the opposing hepatic lipid metabolic process. This is quite a mouthful actually. So what it basically says is there's a concept called diet-induced obesity, right? And you have the liver and the fatty acid oxidation you have, and overnutrition which causes the lipogenesis. Chronotherapeutics, is there a role for chronotherapeutics to treat metabolic disorders? That's the question we need to ask. And I feel this is a promising field now. So you can entrain the circadian rhythms with the help of entraining your feeding time. So if you look here, the circadian rhythm disruption or the diet-induced obesity, glucose intolerance, gut dysbiosis, cardiovascular problems, inflammation, liver diseases, increased cancer risk. The research has shown that there's some role of circadian rhythm disruption and causing colorectal cancer. Other problems are hypocholesterolemia, sleep disorders. So when you do the time-restricted feeding, there seems to be some improvement in the tissue inflammation and arrhythmias, reduced cholesterol, increased sleep quality. Okay, and this is something interesting which I found. Actually, this is the melatonin T2 mutations, which are implicated in type 2 diabetes. When we eat or don't eat may be critical for our health, so it's really important to match your eating habits well and have good eating hygiene along with sleep hygiene. Okay, research has also shown that circadian rhythm problems are correlated with Alzheimer's disease. The next one is in Parkinson's disease. You have the endothelium reticular lipid defects which go on in these neurons. So if you look here, this is actually a normal pattern. Okay, and here you see these ER lipid defects at the ER mitojunctional complex, which causes uncoordinated sleep patterns and rhythms. And to maintain a healthy circadian rhythm, it's really important. And what it does is, the main thing is it causes increased alertness during the daytime. That's what the circadian rhythm does. Second, it gives us better sleep at night time. And third, it also gives us supported health about all the other things that I was discussing. That's the end of my talk. Any questions? Any questions? Thank you.
Thank you, ma'am. So, a small announcement. We are not breaking for tea now. So, snacks and tea are provided outside. We'll resume the next session. But if anyone, people can go in small numbers and have tea, and please come back and join the session. So, moving on to the next session, Narcolepsy Diagnosis and Management by Dr. Deepak Srivastava. So, he's a professor of medicine and sleep from University of California, Davis. Please come on to the desk, sir.
There's something loose. The screen goes out.
Yes, sir. So if we touch this, it's going.
Yeah, that's what has happened.
Yeah.
Narcolepsy. Let's see, play this one. Let's say, go to screen. I want to see if the video is working.
Yesterday it didn't.
Oh, yeah, it's working.
That's the first connection. After the next slide, you can use this new slideshow. It will come full screen. You want full
No,
screen?
just put it on
Full
slideshow.
screen. Okay.
All right, good morning. I apologize that there is no tea break, and I was wondering what if a speaker needs a cup of coffee, what will happen? Okay, this is a little fragile, so I'm going to stay here. Good morning again. I think we will continue. The three speakers this morning, or two speakers, three talks, really set the stage for this talk. It's almost related to the sleep stages and especially pertaining to the encroachment of one stage into the other. So I'm going to talk about narcolepsy. This cartoon which is playing there is actually, there is a purpose to show that. And what it is showing is an hallucination in a person who is waking up. Go ahead. So by definition, it would be the persistent sense of mental cloudiness. So not necessarily sleepiness. You may be just a little slow that morning or that day. A lack of energy, a depressed mood, or extreme exhaustion. So you can see how non-specific these symptoms are. So when you are evaluating the patients and they are complaining about this, what's the differential diagnosis? Everything is included in the differential diagnosis, even in your normal health. Just a long day in the office can make you feel that way. The point here is that in order to diagnose the narcolepsy, which is the subject of my talk, you have to have a very high degree of suspicion to make the diagnosis. And excessive daytime sleepiness, we'll talk about major symptoms of the narcolepsy. Excessive daytime sleepiness remains the most common symptom of the narcolepsy. So here this video is playing, and this is called cataplexy. It was referred to, and then in the next few seconds, she will have a sleep attack. So she's doing a routine of exercise, and all of a sudden has a cataplexy attack and follows into a profound sleep attack. And this can happen when they are driving. You can imagine what the implication would be on something like that. So cataplexy is a sudden loss of muscle tone, and it could be extremely subtle. So you are sitting there, and many times people sit with, they are resting their head on their arm, and then the arm slides, and you will feel like that there's a little bit of muscle twitching on one side of the face, so weakness on one side of the face. So that can be very minor. Individuals are awake, but they are unable to speak, and their eyes are open. So what happens here in cataplexy? Cataplexy has that in wakefulness, REM sleep encroaches in. So the atonia of the REM sleep comes in, and then you don't have muscle tone, you are going to fall down. So it's very simple and very interesting pathologic phenomena that into the wakefulness stage of our being, REM sleep is entering, which normally is not the case. Normally, when you go to sleep, it takes about arguably 80 minutes to 110 minutes before you will have your first REM cycle. The person remains during this cataplectic attack absolutely conscious. That separates it from having a seizure activity. So most common trigger is laughter. Somebody tells a joke or a moment of excitement. So a football player, he is just in front of the goal and he has an open opportunity to score the goal, and he might get cataplectic attack because he got so excited about seeing this opportunity and then will not be able to score the goal because he falls down. Okay, so this is second cartoon. What this is showing here is that the eyes are opening. So this lady is trying to wake up. And this is called sleep paralysis. 15% of the general population, even if they do not have narcolepsy, they can have an attack of sleep paralysis. Everybody in this room either has experienced it or will experience sometime in their life, especially when you are very tired, sleep deprived, etc. You can have a minor episode of sleep paralysis. And when you wake up, so you are in REM sleep, body is paralyzed, you have muscle atonia, and all of a sudden you wake up and you are able to interact with the environment, but you are unable to speak, unable to move, and it can be a very scary feeling if it would last for more than a few seconds. So it's a temporary instability to move or speak before falling asleep or waking, so it can happen at the either ends of the sleep, either onset or offset. Similar to REM inhibitions, to voluntary muscle inactivity, I should say, could last for a few seconds. And during this, person actually remains very conscious. So they remember and they will describe this feeling to you. Okay. This is another cartoon. I hope you can see it. What's happening here is this lady is trying to sleep, and animated object, a scary object is trying to get her. And these are very realistic hallucinations that happen. So just 2 weeks before I came here for the course, I saw a patient who had caused the freeway accident. And what was happening with him, as he would drive to work, he would start falling asleep. And the trees by the side of the freeway, he would describe that these are the giant animals which are trying to get his car, and lifted the car up. So it's such a realistic experience that he moved the car, tried to maneuver, and rammed into other cars in the traffic. And that's how he got arrested, and all this story he told to the police officers. Eventually, judge sends him for evaluation. Turns out that he had these hallucinations that going on. So when they occur during the sleep onset, we call it hypnagogic. When offset, we call it hypnopompic hallucination. They are very vivid. They seem extremely real. They are recurring. The same object will keep coming back to do things. They can be very frightening and may involve other senses. So they may be auditory, they may be tactile, not only the visual hallucinations that you saw in that cartoon. The purpose of the cartoon is so that you can remember that these things can happen, the realistic impressions. So narcoleptics, how about their sleep? They are very, very sleepy. They do sleep correct amount of sleep every night for that particular individual or patient. There is no difficulty in falling asleep, but they have problem in maintaining the sleep. So they have very interrupted sleep throughout the night, so they are not sleeping well during the night, and they are not staying awake during the day because they are very sleepy for the rest of the day. So it's 24-hour disease. REM sleep disturbance may include insomnia, vivid dreaming, sleep talking, acting out while dreaming. You heard about the RBD this morning, lab movement. So there are a variety of presentations that these patients will present. And again, as I said, that you have to be extremely sensitive to make their diagnosis and suspicious. And when it comes to all these symptoms, the excessive daytime sleepiness, sleep paralysis, hallucinations, etc., only 10 to 25% will meet all the criteria. Over the years, the experience is that narcolepsy can start as early as 9 or 10 years of age. And there are sort of two peaks. One is a late onset narcolepsy, but those are not very many cases. Many of these people will be in their 20s and 30s, where you least suspect this is the time that they are sleep deprived, they are college students, etc. So that will mask the diagnosis. And many times the diagnosis will be delayed by many, many years until somebody really suspects. Okay. So what causes narcolepsy? In order to diagnose the narcolepsy, it's important to understand what causes it, because then only you will ask relevant questions in the history. In 1992, so you can imagine that how recent this development is. We knew about narcolepsy in 1970s, in fact, 1972. The Dr. Minia from Stanford has discovered this in dogs with Dr. Dement and company. And Dr. Minia actually happened to speak in our 2011 National Sleep Medicine course in Mumbai. So he had discovered that there is a disease entity called narcolepsy, but what causes it was discovered only in 1992 by two simultaneous groups on the East Coast and West Coast. One called it hypocretin, other called it orexin, but it's the same neurotransmitter, if you will, that is produced in the lateral hypothalamus of the brain. So we'll look at a few things about that. And what orexin does is it has two purposes, crudely speaking. One is to keep us awake. If you have normal orexin being produced in the hypothalamus, that will keep you awake. So your wakefulness, it is concerned with the wakefulness. So if orexin is deficient, you will be sleepy. And then second thing is orexin name, ora, is hunger. It also makes us hungry. So this is one of those hormones. Then there are genetic factors. We'll talk briefly about that. Some autoimmune hypothesis that we are getting more and more scientific evidence that that's what causes it, because many of these narcoleptics will report that they had some kind of flu-like illness, some infection predating their narcolepsy symptoms. And then environmental factors. So if you look at monozygotic twin studies, both twins may not develop narcolepsy, and if they are placed in two different environments. So there may be some environmental factors. We are not sure about what those factors are. So in this cartoon, you will see there are two pictures. And I want to venture with this pointer. Hopefully it will work. Okay, so here's the normal. You can see black dots are showing stained orexin. There are about 100,000 to 200,000 cells in the human body which control us 100%, if you will, in that. And in narcoleptics, these cells are deficient. And the graphic here on the right side of the slide is, if you look at, there's between 100 and 200, 110 is the limit. So narcolepsy with cataplexy patients will be pooled about here, which shows that they have orexin levels in their CSF below 110 picograms per milliliter, versus people who just have narcolepsy without cataplexy, they have the normal levels. This test is not available except for, it is available commercially, but nobody does it because it requires a lumbar puncture, and we will not really confirm diagnosis with that. You still have to have your MSLT and other testing along with the history, proper history, then only this makes sense. So Stanford still does it in many patients, versus all other institutions across the world do know about it. It shows up on the board exams, but hardly anybody does it. Coincident with this orexin, less known, and which should be common knowledge along with the orexin in the context of narcolepsy, is the histamine levels. Histamine, as opposed to antihistamines, which is related to the antihistamine like Benadryl causes sleepiness. That is the ingredient in many of the over-the-counter medications that promote sleepiness. So histamine is responsible for wakefulness. Coincident with orexin level drop, whether it's a compensatory mechanism, but histamine levels go up. So if they are measured, and this cartoon shows the histamine levels in narcolepsy and in the controls. And then we talked about the genetics. The cases in Japan of narcolepsy are almost all of them are DR2 and DR1 HLA positive. So HLA has its association with about 100 human diseases. So this is not very specific for anything, but nevertheless, when it comes to the genotyping and sequencing, it turns out that about 67%, about 1/3 of the African Americans will have positive DR2, and 100% will have this allele, which is DQB1 0602 positivity. So this is an easy test to do across the world. Even in developing countries, this test is easily available. So it can be done on a person where you suspect that there is a narcolepsy suspicion. Most patients with narcolepsy with cataplexy, they are 0602 positive, have hypocretin deficiency. So that is like an assumption. When we see most, again, it says that it is then not 100% sensitive or specific, and that hypocretin level may or may not be positive. So there are borderline cases. So that lowers the predictive value of hypocretin. And there are two HLAs, which is 0601 and 0501 are protective of narcolepsy. So they prevent the HLA molecule to damage the orexin neuron through the T-cell receptor alpha gene. So this is a recent discovery. When I say recent, within the last 10 or 15 years. And what this is showing is that HLA is presenting the antigen to the T-cell receptor alpha gene, and T-cell receptor in turn it has polymorphism. So when there is polymorphism, that can produce the normal protein, which will help and provide the normal functioning of that receptor, or it can have aberrant protein, which is in this case, which goes and then destroys the orexin receptor. And as I mentioned, these HLA can be activated after an episode of some infection. They have looked at most common infection in narcolepsy is noted to be streptococcal infection. And ASO anti-streptolysin levels, antibody levels are found higher in the blood of narcoleptic patients. And then other infections, pneumonia, hepatitis, infectious mononucleosis are listed there, and their adjusted odds ratio. So you can see odds ratio for strep throat are pretty high, 5.4. So what's the diagnostic criteria? We go by the clinical evidence and well-accepted criteria. So you will see the sleepiness lasting for over 3 months, plus one of the following. Cataplexy. If somebody has obvious cataplexy and you are able to recognize cataplexy, you actually do not need any more testing in real world to make a diagnosis. Having said that, in order to get the expensive and high-risk treatment prescribed for the patient, the insurance company, third-party payer, many others will ask for more evidence, and that's when we have to do the testing, and we'll talk about this. CSF hypocritin, as we talked about, exists only in specialized centers, but there is polysomnography, which shows the short REM latency. We'll talk about it just in a second, and multiple sleep latency test. You have to have MSLT mean latency of less than 8 minutes. So you take 5 episodes during the daytime. So MSLT, multiple sleep latency test, is a 24-hour test. Please know that. MSLT is not only day-long test. You have to have a PSG, polysomnography, all night, just to ensure that there is minimum of 6 hours of good quality sleep, free of sleep apnea, free of limb disorders, free of anything that will cause disruption of the sleep. If that is the case, you have to fix that disorder first and then only do MSLT during the morning. Every time you fix that disorder, MSLT still is a 24-hour exercise patient must go through. And then in that MSLT, we are looking at few things. So in night polysomnography, we are looking at how soon the patient falls asleep. So normal sleep latency would be, we can argue about it, but most accepted is 20 minutes. You go to the bed, you should be falling asleep within 20 minutes. If you are not falling asleep within 20 minutes, you may be called that you have sleep onset insomnia. If you are falling shorter than that, how short? So 1 minute, 2 minutes, 3 minutes, either you are sleep deprived or you may have something, one of the differential diagnoses is narcolepsy, and maybe that is first indicator that there is a problem. Then after you have the sleep onset, you went from wakefulness to stage 1 sleep. It takes 15 minutes in narcoleptics or less to go into REM sleep. They very, very quickly go into the REM sleep. As we saw that they enter into wakefulness, the REM will enter and so on. So this happens to the narcoleptics. So if out of the 5 episodes of 2 hours apart, so we have a 6-hour nighttime PSG, patient wakes up, and then 8 a.m., 10 a.m., noon, 2 p.m., 4 p.m., we are doing 5 episodes of asking the patient to go to sleep. Guess what? Patient, what are we testing? Patient says, "Doctor, I'm very sleepy during the day." I don't challenge him. I say, "Okay, well, show me." I'm trying to document, I'm trying to help you, show me that you can fall asleep very quickly. We create the ambience, and guidelines are there. I'm not going to spend time in going over the guidelines in the interest of time so that we can cover the material, but guidelines are there, American Academy of Sleep Medicine. You can download them freely. There's no charge for it or no membership is needed. Nevertheless, but we create an ambience where the patient will fall asleep. And you will see that many of these patients will actually fall asleep very, very quickly within minutes. So their sleep latency, mean sleep latency will come out to be, after calculation, less than 8 minutes. And they will also have more than 2 sleep onset REMs. That means they will go into REM within 15 minutes of sleep onset. So next few slides relate with that information. So here in this cartoon, you can see that within, this is the 1 hour mark here, very quickly this patient is falling asleep, and after falling asleep here, this patient in fact goes into the REM sleep. They have a sleep onset REM in the nighttime PSG that can be considered as number one sleep onset REM period, and then you can have second one during the MSLT. Okay. You have seen these, this rapid eye movement sleep. So here is the typical MSLT PSG result. So PSG, total sleep time of 382 minutes. Sleep efficiency is good, 83%, normal being about 70, 75. And this patient also had sleep apnea, so CPAP was titrated from 6 to 8, and apnea-hypopnea index is normal at 0. But look at the naps. Nap number 1, which would be 8 o'clock. This person, when asked to go to sleep, went into sleep. The EEG, not just the visual behavior sleep, within 1 minute, and REM latency was 11 minutes. Then nap 2, sleep latency was 1 minute, no REM. Nap 3, sleep latency 1 minute, no REM. Nap 4, sleep latency 4 minutes, no REM. Nap 5, sleep latency 1 minute, and then REM latency of 5 minutes. So he had a mean of 1.8, so you add these 5 sleep latencies, divide it by 5, comes out 1.8 minutes. Our criteria is less than 8 minutes, so a patient is really sleepy after a good night's sleep during the PSG. And then documented 2 sleep onset REMs. We noticed that in the PSG there was a sleep onset REM, so actually it adds up to 3. Clearly it supports diagnosis in the right clinical setting of the narcolepsy. Yeah. So we need excessive daytime sleepiness and cataplexy. That is diagnostic. And as I said, you really don't need any further test other than required by either third-party payers or when you start them on questionable therapy like amphetamines. Narcolepsy without cataplexy, you have to have mean sleep latency less than 8 minutes and 2 SORAMs. Okay. We already talked about this, so let's pass. What are some of the common dissociative orders? I think Dr. Tripathi mentioned about that. Her favorite here, REM behavior disorder, is there in 10 to 30% of the patient. But obstructive and central sleep apneas are prevalent in about 1/10 to 20% of the population. Periodic limb movement in a lot of patients, almost 50%. And then other parasomnias, including sleepwalking, sleep talking, night terrors in about 1/5 of them. Since it has to do with the derangement of the orexin, these patients also tend to gain weight. They are also sort of sleep deprived despite the fact because of the intermittent sleep. So their ghrelin and leptin relationship is poor, and then they gain weight. So about 15% of the patient, actually BMI will increase by 15% in most patients. And of course, this is a miserable situation considered to be one of the worst human diseases which lowers the quality of the life, and they get depression. So 1 in 4 will be depressed, and you have to really give them Beck's inventory or whatever other tool that you use to diagnose the depression. How do we treat narcolepsy? Well, we know that this is a disease of sleepiness, so we have to get rid of the sleepiness, and we also know that REM intrudes into the wakefulness, causes symptoms, etc., and has sleep paralysis and hallucinations, so we have to treat it somehow. The FDA-approved treatments are modafinil and the Provigil and Nuvigil, the armodafinil. We really don't quite know that how it works, but we like to believe that it increases the dopamine levels, the feel happy neurotransmitter signaling, and that keeps the people awake. Or then you have this old-fashioned, I don't have to say much about amphetamine and its abuse potential, and hardly anybody uses amphetamines except in specialized centers under special care these days, or methylphenidate, the Ritalin. Again, not very commonly used for the narcolepsy-related sleepiness indication. And then, because the REM sleep is entering the wakefulness and causing the problems, can we utilize the pharmaceuticals which will suppress the REM sleeps? This will be a quick shortcut, but remember that there are a lot of side effects to these therapies, and therapies are listed here, which are SSRIs, selective serotonin intake inhibitors, or SNRI, selective non-epinephrine reuptake inhibitors. So they increase the levels of serotonin in the system, and next slide will show that. So some REM suppressing agents can be successfully used, venlafaxine, fluoxetine, and old-fashioned tricyclics with the attendant side effects of anticholinergic problems with those patients. You don't want to use them with the elderly, people with glaucoma, or people who have benign prostatic hypertrophy. Sodium oxybate or Xyrem is FDA approved for both indications. It works on the sleepiness part and keeps you awake, and also suppresses REM. And it is considered very hard to get medication and has tremendous abuse potential. So it's highly regulated in the United States. Thank you. So we use stimulants they work by dopamine and norepinephrine stimulation. Wakefulness-producing agents are thought to work in dopaminergic, adrenergic, and histaminergic system. We talked about histamine, so histamine levels are already high as it is. And sodium oxybate inhibits the release of inhibitory neurotransmitters like GABA or glutamate and dopamine. And I have the antidepressant SSRI and SNRI and TCA for cataplexy, sleep paralysis, hallucination. Each individual will have a different response to these therapies, and you really have to do some trial and error in the beginning and monitor the patient very closely in order to see the efficacy and minimize the side effects. So beyond medication, the behaviors are extremely important. You have to avoid certain drugs in certain situations. So for example, prazosin, which is given for the control of blood pressure, but also for benign prostatic hypertrophy, it can actually worsen the cataplexy. Some of the antipsychotics, opiates, benzos, alcohol can increase the excessive daytime sleepiness. Sleep hygiene is extremely important to sleep on time, to wake up, and avoid substances. Cognitive behavior therapy, just like in insomnia, really works very, very well. And the immediate goal of cognitive behavior therapy is symptom modification through the counseling and learning on part of the patient. Cognition is modification of belief that I'm miserable, it's not going to go away, my life is over. Those cognitions have to be changed. Behavior, so if they have let's say obstructive sleep apnea, use of CPAP, their behavior has to change, that they have to continue to use the medication as they are prescribed. And of course, education about the nature of the disease, course of the disease, and disability that comes from the disease. And these people need a lot of social support. But cognitive behavior therapy as an adjunct to the medical therapy is extremely important and should be applied. So in conclusion, narcolepsy with cataplexy is associated with hypocretin loss in 95% of the people. Remember, those 5% people, there may not be the case, and they may have something atypical that we don't know. We need to know about that. Narcolepsy appears to be an autoimmune disorder, as we suspect, because of the onset after the winter months when they have flu-like illness, common cold-like illness, viral infection. HLA-DQB0602 and the T-cell receptor gene association with narcolepsy and cataplexy point to an immune system problem. And infection may be the commonest cause of precipitating narcolepsy. Sodium oxybate, or commercial name Xyrem, is the most effective medication in narcolepsy. And future treatments may target hypocretin and histamine systems, and they will be hopefully more efficacious with minimum side effects. So thank you so much for listening to me, and I hope you learned something during this talk. Thank you. And you are not hallucinating. I put that spider there.
Thank you, sir. Next, I would like to call upon Dr. Manjari Tripathi to talk on insomnia, current concepts and diagnostic techniques. Okay. Who's that?
Just double click and then open it.
This one? This one? Sleep disorder.
Karuna Datta, no, insomnia, hyperarousal. Yeah.
No slideshow. This one.
Yeah, do that. I want a slideshow.
Yeah.
Okay, so thank you very much. Okay, so before we start insomnia, okay. Okay, so I keep it back. Okay, thank you. So before we start the session on insomnia, I must thank the organizers and the coordinators to give this little talk for what are the current concepts of insomnia. And as we understand is that chronic insomnia develops from a state of acute insomnia. Now, initially it was thought that there has to be something associated which causes acute insomnia to become a chronic insomnia. But what is it was not much known. And as research or more evidence started to come, there were some theories which were postulated. So in the next probably 20-25 minutes, I'm just going to go through the history rather, or I would say how it's developed, and leave it for my next speaker, Dr. Ramadevi, who's going to talk about the therapeutics, the evaluation, and how does the pathophysiology of insomnia, how does it help us to actually help us find out how do we use the pathophysiology to our benefit to help in the management. Now, acute insomnia is generally some episode or some trigger which has happened because of which the patient has problems initiating sleep or maintaining sleep or wakes up too early in the night. We discussed the classification yesterday of insomnia. And what happens in acute insomnia is that there are various things which are now postulated as highlighted here in front of you. Oh, the slide is not showing. Yeah. So various things which are postulated like, yeah, so if you see this first graph, there is a threshold which is there. And if a stress response goes beyond the threshold, you find it can be a life event, a significant one, mostly one which really causes sorrow or grief or an emotional response. And if it causes a stress response which crosses the insomnia threshold, it can lead to an episode of acute insomnia. Now, the second thing is that it can be not so acute, or rather I would say it may not be such a big trigger which you can pinpoint to, but it may be something which has accumulated over time. And that is where a very good history taking plays an important role, because you need to actually identify, pinpoint these things as to how it evolved, the process evolved. And like in the second one, we can see that there is accumulation of daily hassles, as innocuous as that. And that accumulation have a response to a situation where they are hyperaroused. But recent literature, in fact, there's a recent publication in 2018 by Kambach et al., which I'm going to show you some slides from there too, where they said that this hyperarousal model, which we talk about, is very unique in the sense that pre-episode, both of them, a person who's likely to have insomnia or not likely to have insomnia, may have the same basal arousal. That means their cortisol levels were similar, their heart rate variability was similar, and many other parameters which they used were quite similar. But when a stress factor triggered, something happened to this person, one of them who was likely to develop an insomnia, that he showed an exaggerated response and he became a case of hyperarousal. Now, what is this differentiating line? I'm sorry to say, still not clear in science. But at least now we know it's not a continuous hyperarousal model. It's not somebody who was born with hyperarousal who ends up in insomnia. But he was apparently normal, as good as anybody else. But something happened, and there his response to stress was different from person B. There's a lot of interesting, thought around this, that what was it which caused the change? Now, one perspective may be that the condition, as we see now all these things, accumulation of daily hassles, all this, jargon now fits in, significant of a life event, chronic stressors. Everybody is undergoing stress. There's no single individual who's not undergoing stress. But not all of us are insomniacs. That means there is something more to it. So is it that we have a kind of a reactivity to stress? Is it that we react to stress in different ways? And that is what this paper is all about, which I'm just going to tell you about. So what exactly happened is the fifth thing which I want to show you, that there is something which is causing you more vulnerable to the stress. So this stress vulnerability has made you cross the threshold where your stress response is now going to eventually lead to an acute insomnia. We're still at acute insomnia. We've not reached chronic. The last one is that you have reached, and the threshold vulnerability is there, so your threshold may also get altered. And there's a recent article in psychiatric journals where they've said that the emotional and your sleep are bidirectional processes. Meaning, if your emotional state is different today, I will react differently to my stressors. So that basically means it's a multifactorial story. Today, I might end up in an acute insomnia episode, and tomorrow I may not. But the bottom line is that once I have an acute insomnia episode, do I revert back? Or do I go into a chronic insomnia model? Now, this is where, as a physician, probably we play an important role. Because if there's a death in a family, if there is, a major event, it's likely that your sleep will be affected. In fact, I would not call it as a disease at that stage. But let's say it continues for 3 months. Generally, 6 to 8 weeks is what we give. But let's say it continues to 3 to 6 months. And now also he is not able to sleep. That is where your intervention is important. Between that 6 weeks to 6 months is the window where we can change this acute insomnia to a normal or to a chronic insomnia, or at least we can help him out in some way getting rid of it. So if we have to discuss chronic insomnia, the typical 3P model which was postulated was that there are perpetuating factors, precipitating factors, and predisposing factors. And it stayed at that. It said as we go from pre-morbid, acute, early to chronic, it is the perpetuating factors which are actually playing an important role, because your predisposing and your precipitating are still below the threshold. But perpetuating are the ones which are going to take you likely to cross the threshold and make you into a chronic insomnia. Also on the left-hand side is a neurocognitive model. It's a big thing. I'm just going to discuss it. It's something which is there in Krieger, Roth, and Dement in the principles of sleep medicine, but without it, we can't go ahead. So if you see this, I'll just go through it from top to bottom. We have some predisposing factors like biophysical, social factors, which may be there. We have precipitating events, as we said, some stress, some event, some life trigger, something. And then we have the perpetuating factors, the 3P model. So perpetuating factors would be now how the response is happening to this entire scenario where the person starts to extend his sleep time, starts having coffee, caffeine to keep himself fresh, or starts altering his sleep hygiene principles to find a solution for this entire story. And this perpetuates. So this perpetuating factors is what is important for this acute to chronic insomnia. And that is why I said that if you're able to explain the role of sleep hygiene at 6 to 8 weeks when a person has come with acute stress, explain the role of behavioral therapy, cognitive therapy here, this is the place where we may revert the incidence of going into a chronic insomnia. In the middle, the big box, is the neurocognitive factors, where we have a conditioned arousal as one, and the cognitive alterations. Now, what are cognitive alterations? It has been known now with research that these patients who are chronic insomnia patients, they have increased sensory processing, meaning they will remember what happened in the night after they went off to sleep. They will even remember there was a knock at the door, the temperature changed in the room, so-and-so was speaking something, or it may be even altered sensory processing. They might over-exaggerate to a certain event. And this is actually a part of your cognitive alterations. So, other cognitive alterations are that you actually are making long-term and short-term memory out of this. So you will remember these details in much finer aspects, and this is where you will remember these details. And in neurophysiology, we say it's all about the rumination and worry, So more you think about it, the more it gets ingrained, the more it becomes a pathway which is more facilitatory, and more it keeps on playing on your mind. Especially in emotional responses are the negative responses. So we always say that the two principles of learning and memory are reward and punishment. We all agree? All children either do work for a chocolate or because they're scared of something, the teacher or whatever. We have all used these principles. But it's the negative emotional component which has a fast entry into our long-term memory than the positive emotional component. Although we say they both play an important role, but somehow negative emotional component just keeps everything aside and goes in first. So what happens in these patients is, not only in a normal person also it plays a role, but in these patients it's an exaggerated thing. These people will remember a negative connotation to a thing much more. They will remember more sensory information, more burden, unnecessary garbage which they are collecting. And this is also responsible into the pathophysiology. Now, whatever it is, whatever happens, wherever the problem is, finally it leads to chronic insomnia, and the patient complains that I can't sleep at night. So here is your patient now who has developed chronic insomnia. We all know this. This is something which all of us as doctors have faced it ourselves and even seen it. But is it that all of us become insomniacs after stress? No. We all, just go through it. We're done with it. We come out of it. We start sleeping again. So the new theory says that maybe there is a dysregulation of stress in chronic insomniacs, meaning they had a response which was not normal. Now, if that is the case, is it that this cognitive factors which were underlying, which anyway, high increased sensory processing, rumination, worry, long-term memory processing, short-term memory processing of negative components, all these things are going to make this stressful condition. You will keep on thinking, why did my boss say like this? I never did anything wrong. I should have done this. Why didn't I do that? Things like this. And that is where this normal stress event, I would not say normal, nothing is normal, no stress is normal, but a innocuous stressful event in life becomes a cause for insomnia. So it's something where a dysregulation to the response to stress has happened. And this is now one of the most important theories, where it is not what you had, but it is how you responded. It is not what events happened, but how you responded to it. That is the cause probably for developing insomnia. So coming to this paper which I was mentioning, that you have a stress reactivity by different body parts. We all know the palpitations we have before exams, the urge to go to the washroom, all this is here. Gastrointestinal hyperactivity, emotional reactivity, cardiovascular reactivity, and you may also have a sleep reactivity. So these sleep reactive individuals, as per this paper, they conducted a study where they found out that you have highly reactive and one which don't react much. So what was the difference between the two? The difference between the two was that following a stressor in the lab, when they had a nocturnal wakefulness in the patient, that means VASO was high, sleep onset latency was high, so obviously the sleep efficiency was lower. They found that in the morning, in the MSLT, what should have happened in a normal person? He should have slept. The sleep onset latency in a MSLT should have been less than 8 minutes. That's what we just saw in narcolepsy. But what happens in this person is that the sleep onset latency is normal. He doesn't sleep in the morning. That means he had a case where he didn't sleep enough in the night. He had a bad sleep efficiency, but he also responded by being aroused in the morning too, where even in the MSLT, he did not go off to sleep. This characteristic in lab, if you witness, is probably a marker for a highly reactive person. And lab stressors which they used was something like caffeine use, which is so innocuous. Simple things, caffeine use, or something like, a kind of a PSG adaptation night where they see what happens to you. And they found that this person did not sleep at night, but in the morning also, in MSLT, he was not able to sleep. That means he is showing evidence of hyperarousal after a lab stressor. And these are the ones who are reactive. They react by sleep with stress. So somewhere the stress has percolated into their sleep. But before, they were normal. If you compare the two groups, highly reactive and the low reactive ones, there wasn't any difference in the cortisol levels. There wasn't any difference in the HRV parameters. There wasn't any difference in their sleep patterns. So they were apparently normal, but somewhere they reacted differently. And that's what happens, that when you are a sleep reactive individual, now the story becomes more towards your insomnia, where it will start becoming a cognitive emotional reactivity, where you will have pre-sleep rumination, worry. As it is, the processing is little getting altered with lack of sleep. Emotional and sleep bidirectional problem is also there, so you're going to be more irritable, leading to further, it's a vicious cycle then. And this will lead to a problem, or it would basically make chronic insomnia. Now, the problem is that in this study, where I would say the problem is, as we were discussing, I was discussing with Dr. Rama also yesterday, that we generally think of only primary insomnia. We only think of, I would not say primary insomnia because it's an old definition, what we used to use in ICSD-2, but now we don't have that primary insomnia concept. But I would say if it's just a single insomnia only which is there in the patient. But you find this problem also when it's associated with other disorders like hypertension. We had this talk yesterday, where it can be associated with many other disorders. So is this hyperarousal model true there too? Yes, we don't know, but some research shows yes. But a treatment of a comorbidity is as important as treatment of insomnia. Now, in India, rather, I would say that mostly we are treating the comorbidity, but we don't pay attention to insomnia. It will not get cured. The insomnia will not get cured. And the vice versa is also true. If you only look after insomnia, but you don't look after the other disorders which are there, Insomnia will not get cured. So my request is that when we're doing pathophysiology, always look for other causes, and more will come in the evaluation and in the management. So look for other causes, and we should be sure that the management of the other disorders are also done. So how do you diagnose insomnia? Now, generally what we follow is a polysomnography is often not indicated in diagnosis of insomnia alone. And what we do is just sleep logs, sleep diary maybe for 2 weeks, actigraphy, and sometimes questionnaires, which gives us a reasonably okay idea of how insomnia is. Now, ASM criteria says that it should be at least for 2 weeks. So don't just take history of 2 days and feel it's insomnia. It should be for 2 weeks. And chronic insomnia is, as we discussed yesterday, it's for at least 3 times a week for at least 3 months. Unless you have this criteria there, we can't call it as chronic insomnia. Now, when do you do polysomnography? Rather, when do you do actually actigraphy too? That is, when you're suspecting other disorders with insomnia. It may be a circadian rhythm disorder. It can be some restless leg syndrome, very commonly associated with insomnia. It may be a OSA, which you're suspecting, again very commonly associated with insomnia. So don't forget diagnosis of other disorders, other sleep disorders, and if you're suspecting any one of them, don't hesitate from doing a polysomnography. So the bottom line is, I hand over to the next speaker with saying that pathophysiology remains, there's a difference in the reaction that you show. You are more sleep reactive and you become a chronic insomniac. And what you must do for your investigation is not only to diagnose insomnia, to diagnose other disorders and other sleep disorders. I've finished. Any questions? Any questions? Thank you.
Thank you, ma'am, for the wonderful talk. Next, I invite Dr. Ramadevi Gauraneni to talk on treatment of insomnia, pharmacotherapy versus cognitive behavior therapy.
I just made some changes. You can just put on the desktop. Hello, everyone. Can you hear me? Hello, everyone. I'd like to thank Dr. Malik, Dr. Appad, and Dr. Srivatsava for giving me an opportunity to come here to Chettinad Institute to talk about the treatment of insomnia. I'd like to speak about the broad perspective. No. It's NSM. Not that, because I just put it in here. No. Can you pull this up? Sorry, I spent a lot of time putting slides in, then I spent a lot of time taking slides out. So there's been some changes here, this one right here. What I'm going to talk about is the broad perspective from a clinical standpoint of how to approach a patient with insomnia regarding treatment. And thank you so much, Dr. Karuna, for talking about the pathophysiology of insomnia and also starting to talk about the evaluation of insomnia. So the learning objectives for my lecture is to understand the various behavioral pharmacologic agents available for treatment of insomnia, and also develop comfort in selecting appropriate therapy. It's not one package doesn't fix all for insomnia. I've been seeing patients with insomnia for over 15 years. And since I've said that, I think it's been 5 years, so maybe closer to 20 years. No two patients with insomnia are exactly alike. There's so many things different about them, so you can't expect the same treatment is going to work for everybody. So treatment for insomnia needs to be individualized. It's not a matter of saying, I can't sleep and giving them a medication. So just a reminder, appropriate clinical evaluation is the key to effective treatment. Unless you understand what's different about your patient from others, you're not going to be able to decide what treatments are going to work for them. So what is the relevant medication in psychiatric history? Medication, what medications could be causing the insomnia or perpetuating insomnia? Very detailed sleep history, including evaluation for underlying sleep disorders, such as restless legs, sleep apnea, and circadian rhythm sleep problems. See, the treatment for those conditions is completely different from other types of insomnia. And also, what are the social and lifestyle factors for this patient? And what are maladaptive cognitions related to sleep? And even sleep physicians find that they may not have time for this, but unless you have some type of streamlined approach for obtaining this history, your patient's not going to receive the correct treatment. So let's talk a little bit about the lifestyle factors. This can be part of your social history. Like, do you drink caffeine? And I want to talk a little bit about my experience of the insomnia patients I've been seeing in Tirupati, which is a tier 2. Some people consider it a tier 3 city. But I also see a lot of people from the rural places. Caffeine's not been as much of a player for insomnia in the patients that I see as the patients I saw at Northwestern in Chicago. Over there, people start with black coffee this big, but here, most people, it's little cups of coffee 2-3 times a day, and a lot of time mixed with milk, so it's not been as much of an issue. But when you go to metros, it's still an issue, especially in younger folks, because in the evening, before they go to workout, they're taking pre-workout supplements that contain high doses of caffeine, and that can really affect their sleep. Alcohol can put you to sleep, but it's going to wake you up again. Stressors. Exercise, again, exercise is good, but if it's done too late in the evening, it can affect sleep. And with the tier 3, tier 2 cities, it's not much of a problem even in rural areas, but in the metros, you need to keep this in mind. Dinner, people eat dinner very late in India, much later than what I remember in my childhood before leaving for USA. So part of it is if they eat a late dinner, it can cause GERD, but it's also the day hasn't ended until you finish your dinner and all the activities associated with dinner. So having a late dinner can also be disruptive to sleep. Sunlight exposure, social activity are both good for you during the daytime. Sunlight exposure is not a big problem here in India, but the social activity, especially for elderly patients that are ill, this whole idea of bed rest, giving them rest, not making them do anything. And the minute you sit them down and the caregiver leaves, they're falling asleep all day. So that's going to affect their sleep at night. So there are evaluation tools, and Dr. Karuna has talked about some of this. AESM sleep diary is very useful. It's on the net, and I'll talk about that in a minute. Actigraphy is expensive. It can be helpful when you're talking about patients with, one second. When you're actigram, see, this is a double day, and the patients with circadian rhythm sleep problems, shift work sleep disorder, are people who are not able to maintain a sleep diary. If you want to look at their sleep-wake pattern over a period of weeks, this is helpful. But again, there is a cost associated with it. One of the main problems that I face in Tirupati is cost effectiveness, so this is something I've not instituted. The sleep diary is very helpful. It's a diary because it's not just the sleep in the wake, but it's the caffeine, the alcohol, the exercise, everything you're keeping. When you take a sleep history in your clinic, what people say and what they do is completely different. So having them keep a diary for 1 or 2 weeks is important. I recommend 1 week because after 2 weeks, a lot of people don't come back. So if you have them come back in 1 week, they'll also agree to what they're doing. Otherwise, if you tell them you may or may not be doing this, a lot of times they don't listen to you. So I don't know how many of you can see this, but this shows an example. This is a patient. If you see, there's a lot of daytime napping. And see, time in bed is variable, but it's a daytime napping that's really affecting the patient's sleep. Here, later when we start limiting this napping, you can see that the sleep consolidation starts to improve. So with this said, What are the goals for insomnia treatment? It includes cognitive behavioral therapy, pharmacologic therapy, and a combination of these therapies. So Dr. Karuna also already went over this, but just to add, see, this is the threshold for insomnia, this blue line. People's threshold can be here, lower, it can be very close, and that's the individual makeup of the person. It could be the hypothesized hyperarousal, but hyperarousal, the presence of it has been scientifically, I think, more accepted because of the functional MRI studies that shows the increased metabolism, certain areas of the brain that doesn't go down with sleep. So hyperarousal is a much more touchable phenomenon right now. So some people are much more prone to developing difficulty with sleep. But when there is a big precipitator in orange, people develop insomnia, which should go back to normal once the stressor goes away. But it's these habits in blue that they develop that perpetuate the insomnia. And some of these examples include older people thinking, I'm not sleeping, so let me take more naps so I feel better. Let me spend more time in bed so that I can sleep better. But this takes away the process S so that your sleep is disrupted. Another example is every time a good sleeper, how many good sleepers are there in this audience? So what emotions go through your mind when you see the bed? Very happy. Yeah, even especially when you're a medical resident and you see the bed, you feel happy. When you change your clothes into your night clothes, you feel happy. When you're brushing your teeth before you go to bed, you feel happy. But if you're a poor sleeper and you've had difficulty sleeping, every time you look at the bed, it's not a good feeling. You feel bad, you feel anxious, you feel nervous. So those are the cognitions that develop. One other thing, this has been repeated many times, so I won't go into it in detail, but just see here, this is when a person wakes up. So the circadian drive to keep you alert goes up. Here the process S, or the homeostatic drive to put you to sleep, also goes up until the time you go to sleep. Then that dissipates. So there's two things here. In the afternoon, the circadian alerting drive is really low. So your chances of falling asleep in the afternoon are high. And taking a small nap in the afternoon is okay. But if you take prolonged naps, what's going to happen is this homeostatic drive to put you to sleep is also going to go away. So how do you decide whether to use behavioral versus pharmacotherapy? What studies can guide us? One, behavioral therapies are as effective as pharmacotherapy in the short run. There's many studies that have shown this from the beginning. But when you look at long-term follow-up in 6 months afterwards, so actually even going back to short-term, see, day number 1, the medication is going to help. But if you stay with the behavioral therapies, after a week, 2 weeks, 3 weeks, you'll start sleeping better. But if you stop the medication, even after 2-3 months of therapy, what's going to happen? 6 months later, the person who had medication therapy and stopped it, they're not sleeping. And it may be worse than before. But people who have learned the proper behavioral therapies, their sleep continues to be improved. So as you can see, CBTI should be the proved choice. And the other experience that I had when I started as a faculty member, if you start giving hypnotic medications, it's too easy to fall asleep. They have no motivation to learn cognitive behavioral methods because they're already sleeping. So in general, as a rule, I used to try to avoid hypnotics as much as I can. But this one study is food for thought. There's another study that looked at CBTI, zolpidem, and combination therapy. And what they found is CBTI and zolpidem produced significant improvement. But when you looked at the long-term results, when they started cognitive therapy for insomnia with zolpidem and followed by a tapering of zolpidem, this group did the best. But when you look at the actual numbers, even the best isn't much different than CBTI alone. So I think this study is important, showing that when you tell a patient that you'll start a medication and then you'll taper a medication, that they will do good. But at the same time, it's not motivated me to use this approach on everyone, because still not a big difference from CBTI alone. So behavioral therapies, what are the looking at behavioral therapies, when you look at the practice parameters, and the NIH State of the Science Conference statement in 2005, they say psychological behavioral interventions are effective and recommended in the treatment of chronic primary insomnia. At that time, the term primary insomnia was still used, and secondary insomnia in adults. It still works in secondary insomnia, but there's a lot of factors, like if it's insomnia associated with chronic pain, you may need to use hypnotics in that patient. And also, it should be the first-line treatment for all patients. So how do you know if CBTI is the right treatment? What are the other options available? See, there's no treatment and there's medication treatment. But hopefully, the reason you're not doing cognitive behavioral therapy is not because there's no one to do the cognitive behavioral therapy. That's very realistic, and we should try to change this. It doesn't have to be doctors that do the cognitive behavioral therapy. It should be someone that's part of the team. It could be a psychologist, a nurse. Do they understand the patient? You have to tell the patient what's involved. Otherwise, it's frustrating for both the doctor and the patient. What I'm seeing more and more people that come from faraway rural areas, they want you to fix their problem right away. And unless you can explain to them exactly what it's going to take on their part, it's going to be a frustrating experience. You have to tell them medications are available, but these are the issues involved with medications. And behavioral therapies are available. This is what I recommend. But this is what it's going to take from your side also. Are you willing to do it? See, now you've put the ball in their court. They understand that they also need to be involved. Otherwise, next time they'll go to a different doctor. Or they'll say, I went, but it doesn't work. And if they're already on sleep medications, do you taper sleep medications? One thing is if they're not sleeping even with medications, it's probably not good to initiate medication taper during the first appointment. Wait till they start sleeping better, and especially if they're on multiple medications, try to come up with a reasonable strategy of how to taper the medication. They should never be stopped, but they should be tapered slowly over a period of a week or more. But remember, this takes time. It's not a one-day fix. It takes time on the part of the clinician and the patient. So if you've decided that CBTI is the way to go, this is the multi-component CBTI. It consists of education about sleep, about insomnia, about the hyperarousal, about what are good sleep habits. There's behavioral approaches, there's cognitive approaches, and relaxation methods that you can use. Now, out of this, what are the standards? The standard includes sleep restriction therapy, stimulus control. Multi-component CBTI is also a standard. When I first joined sleep medicine as a fellow, relaxation methods, they kept saying that there's no evidence, but now I always felt that they would work, that there just wasn't studies, but now enough studies have been done. It shows that they are effective, and this has become a standard. Everything that Dr. Karuna talked about, hyperarousal, the relaxation methods, the yoga, the meditation, it works against the arousal and relaxing the brain. So, sleep habits. What are good sleep habits? It's good to have a regular sleep-wake time and not vary it too much. You can vary to some extent on weekends, but within the weekdays, try not to vary it by more than half hour. Avoid late napping, because if you remember, the process S is what you need to go to sleep. So if you take long naps at the end of the day, especially in elderly people or throughout the day, the ability to go to sleep at night is going to come down. Avoid excessive caffeine, no more than 3 cups of coffee per day, 3 regular cups of coffee, and none in the late evening. Exercise can promote good health, but avoid heavy exercise 3 to 4 hours before bedtime. Avoid heavy meals 3 hours prior to bedtime. Avoid smoking and alcohol close to bedtime. All of you practicing sleep medicine should have handouts of this. If you'd like me to share mine, I can share mine. But don't just give them the handout. You have to see what they're doing wrong and coach them based on that. The reason studies with sleep hygiene haven't been effective is people don't spend the time to explain to them what they're doing wrong and why they should do it differently. If they did, I think the studies would be a lot different. So bedtime is also very important. The picture that you see over here, I don't see it anymore. That's the problem. before, especially in the rural areas, bedtime was such a prolonged process where people had time for their mind to relax, tell stories, and put the day behind them, feel totally safe as children. But now everybody has their own thing, and the easiest thing to do is to leave the children with their own thing. So it's not only a matter of hyperstimulation before bedtime, but it's also, I think, indication of poor family structure and function in the family also. So you should avoid stimulating activities before bedtime, but especially avoid screens, cell phones, laptops, and iPads, because the blue light that's emitted is going to cause suppression of melatonin. Also, it's very stimulating. Avoid bright lights. Internationally, when you travel, there's dimmer switches on all lights, but there's no dimmer switches in India, so it's very bright light. So those type of lights should go off at least an hour before bedtime, not only for you, but also for the entire family. And the amount of noise that you're exposed to and the time in bed is increased or reduced by 15, 20 minutes. It's effective. However, it's very difficult, and very few clinicians I know actually follow this. But some of the precautions about this is the sleepiness. You should never make a patient spend less than 4 hours in bed. But even then, when you reduce the time in bed, the sleepiness, it can cause problems at work, problems with accidents. If a patient has underlying bipolar disorder, again, the sleep deprivation might provoke mania and other health concerns. So another therapy that's more doable, similar to sleep restriction, is sleep compression therapy. And there's no definite outline on how this is done, but it's trying to reduce the time in bed to an extent that's more tolerable, like 5 hours, maybe 6 hours, depending on the person, and increasing the time based on their response to the treatment by using a sleep diary. And this can be done for people that are busy with really serious work at the time. But after 2-3 days, people start to feel really sleepy because of bringing up the process S and start to sleep. And again, I've used this maybe 2-3 times in my entire career. Stimulus control is a standard. It's also very important, not only for multi-component CBTI, but along with sleep compression, it can be used for brief behavioral therapy. And again, this is to take away the cognitive association of the bed with not sleeping. This is done by telling them to go to bed when they're sleepy, as long as there's a specific regularity. But if they wake up in the middle of the night or are unable to sleep, rather than lying in bed trying to go to sleep, and then their brain starts thinking about all of these things,